this recent study. Can you comment what antioxidant or oxidants were studied in a controlled way?
Sure, there were a number. The last slide that I showed where we just tested generic antioxidants, there were some chemicals that were chemically classified as antioxidants, and then there were a number of vitamins that protect cells from oxidative stress, not necessarily through a direct chemical method or mechanism, but through like secondary mechanisms that make the cells more resistant. So pretty much any antioxidant in this simple cell-based assay will have that effect. There were, all the antioxidant vitamins, vitamin E, vitamin K, as well as a number of other compounds. But as I said, earlier, it's a fine line. The difference between a drug and a poison is the dose, right? And so and I think it's important to not sort of take the results from a cell-based assay and extrapolate them automatically to a treatment. I think it's one small piece of evidence that might be used to justify a clinical trial in humans, but it's only a small piece of evidence, and there's a lot of extrapolation from what's happening in these cells. This is also, the assay that I showed is an effect of high levels of DUX4, and the oxidative stress pathway is probably not activated by very low levels of DUX4, and those low levels might actually be doing something. They might even be more important than the high levels with regard to the disease. We just don't know. And so there are many, many unknowns is the upshot.
And so maybe if I can add from what I know about the study ongoing in Montpellier by Dalila Lauj, that she had to discard a number of patients from the trial because they were taking antioxidants on the side, in addition to the pill that was given to them from the clinical trial. And of course, in that pill, they didn't know whether they had a drug in it, an antioxidant, or whether it was a placebo, that it was just sugar. And some patients considered that they needed to have additional antioxidants. And so that was screwing up everything, so they had to be discarded from the trial. And so it's something very general. A little bit of free radicals is very important for many processes in your cells, in your body. And if you take a large amount of antioxidant without any control, then you might screw up many things in your cells. So from what has been said by Michael Kyba, from what I mentioned about the antioxidant trial in Montpellier, please do not take the conclusion that you go to your drug or pharmacy and ask, give me a bunch of antioxidant, I will take that by myself. This can be very dangerous.
A couple more questions and then we'll...
Hello. I have a couple of questions. One has to do, I'm an epidemiologist, so forgive me the question. Are there any studies, or is it even important to know whether there are regional, racial, any kind of familiar differences among the occurrence of cases at different ages? I know there are very few cases, but is there anything, I guess there's an NIH database, is there anything that tells you any sort of hint about genetic makeup related to the disease? That's my first question. And the second question is, I have the disease, but my sister, only one sibling, also had pseudoxanthoma elasticum. Now, my understanding is that is not associated with FSHD, but the first question is really the most important. But I just wondered if there was any other diseases that are genetically based that seem to be occurring more often in FSH patients.
That's an interesting question, and one question we were wondering, is there an increased risk of cancer in patients with FSHD? Has anybody ever done that type of study? But basically, I think your question should be asked to the clinicians, and so this is not this session, it's coming. Now, you could imagine, if you keep in mind this chef cascade, so chef number 1 giving order to chef number 2 and 3 and so on, when you activate the DUX4 gene, you produce the DUX4 protein, CHEF, which is named transcription factor. It will activate a deregulation cascade involving hundreds of genes. So that you could imagine that among those genes, from one individual to the other, there could be small differences that will make the disease worse in one person and that will give some kind of protection in another person. So that besides DUX4 activation, which I think everybody agrees that it has to be there could be variations from one individual to the other. Those variations in some genes cannot by themselves cause a disease, but in addition to the DUX4 deregulation cascade, it could make the disease worse or less bad. And this we don't know.
If I could just add quickly to that, I think that you're asking a very difficult question because of the nature of the mutations that cause FSHD. And so in most diseases, the mutation that causes a disease is fairly standard. But so, for example, in FSHD2, there are multiple different mutations that cause FSHD2. Some of them knock out the protein for SMCHD1, but some of them cause truncated proteins that might have other functions. And so even though a specific mutation in FSHD2 might be associated with another syndrome or disease as well, it's not going to be with all SMCHD1 mutations or all other FSHD. And so teasing that out of the population will require a very large number of individuals and a very specific identification of the mutation. And then you can get further complicated even in FSHD1 because the different methylation patterns and epigenetics in different tissues might manifest themselves differently. And so I think the real answer to your question is it's going to be very difficult to say either positively or negatively whether syndromes are associated with the mutation that causes the primary disease.
And finally, when you have chromatin opening, so the part with the repeated elements that have the DUX4 gene gets open and can be expressed, also the genes in the close vicinity get in open chromatin. And for instance, DUX4C is increased also in FSHD. DUX4C alone could not cause the disease, but DUX4C together with DUX4 is contributing to the pathology. So that you have those other genes are probably also playing a role, like FRG1 for a long time was thought was the cause of FSHD, and probably contributes also partly to the disease. So it's very complicated.
Question in the middle.
So, Dr. Tapscott, from the improvements in the molecular, this is Frank here, from the improvements in the molecular understanding of the causative elements of FSHD, are there opportunities for an improved diagnostic set of assays?
I think absolutely, and I think one of the, right now, if you do a muscle biopsy, there are now candidate biomarkers from that muscle biopsy that can be monitored. That's obviously not necessarily for diagnostic purposes, but for clinical trials or following therapies. What we and many others are doing is to look for less invasive markers that could be used either in the serum or, we're very excited about the use of MRI as a mechanism of monitoring disease and aiding in either diagnosis or clinical trials.
One more question in the back. Turn that question, Dr. Fitzsimons.
Thank you. It's really just a comment, if I may, on the question before last, which asked about specific racial groups. In my observation, and having worked for some time, I'm Australian, but having worked in the south of England, and also looking at the literature, it seems to be remarkably rare in the black Negro population. In fact, if you look around this room, for instance, I think that would possibly bear that out. There was a paper from South Africa reporting experience with FSHD, and all their patients were Caucasian. It's common to my knowledge in Indian and Chinese populations, There was one case report of identical twins mirror images from America reporting it in Ethiopian patients, but that could be ethnically anything. So I just thought I'd make that comment.
And Ms. Serta, right here in the front.
I saw a lot about how you guys were trying to like stop the production of DUX4 or stop it somewhere along the process, but have there been any studies done or any thought of not stopping DUX4 exactly, but maybe redirecting its course to where it attacks? Since is there a reason that it's only present in muscle cells, and what causes it only to be in muscle cells that you could replicate with some compound to redirect where it kind of, instead of killing off the cells, it would kill off this thing that you would redirect it to?
Yeah, I'll say something. I'm not sure it's a direct answer to your question. But so just want to address the idea out there that DUX4 is present in muscle cells, and specifically present in muscle cells. It's actually very, very, very difficult to see DUX4 in muscle cells. It may be present, as Dr. Tapscott's lab has shown not too long ago, in rare cells, 1 in 1,000 or something like that. But it may also be present in cells that are not from an FSHD individual at extremely low levels. We don't really know. But it's not present at a level where you can see it and be confident that it's there in the way that other proteins are that are associated with other genetic diseases. So it's one of the reasons that that research on this protein has been controversial and sort of underfunded for many years, is because is it really there? And then is it really specifically expressed in muscle? So if you take blood from patients and do these epigenetic methylation studies, you get interesting results suggesting that patients with FSHD2 have extremely low levels of methylation, and on the affected allele, patients with FSHD1 have lower levels of methylation, and that's all coming from the blood. So these changes are present not only in muscle but also in blood, and I suspect that they're actually all through the body. So I'll redirect your question. So probably DUX4 is expressed in all tissues at extremely low levels in FSHD. Why is it specifically in muscle that it's more toxic, apparently, over the long run? Is it because it's expressed a little higher there than other places? Is it because it is only expressed there? Or is it because it's somehow one of its targets is more toxic to muscle? Those are complete unknowns right now. And then the question of, can we redirect DUX4? In some ways, when you do a blind screen and you use a particular readout, like death of cells, as your assay, you don't really know what you're doing. When we protect the cells from cell death with some compound, if it was directly interacting with the protein, it might be redirecting the protein's function. We don't really know how it's inhibiting it. And so once you find such a compound, then you have to follow up with studies that address what is that compound doing.